Awesome. Well, welcome back, Mr. Larry, for another week of this fantastic podcast of Muscles and Minutes, bite-sized bits. So I think we were just kind of finishing up talking about some fun things that we want to talk about this week in terms of just general protocols and kind of physical therapists kind of taking the lead. And, I think what we were just talking about is actually a great way to start, because I know we can kind of follow it up with, once we find that study that we were talking about, we can kind of add it in. But just kind of starting with, my name is Dr. Cole. I'm a physical therapist here at Phoenix Fit Physical Therapy. And, my passion is just kind of the outpatient world, especially with athletics and sports and performance. And then I just love talking all things therapy.
Awesome. I'm excited.
Yeah. Why don't you reintroduce yourself, Larry? And then, we'll kind of get on to the topic of today. And kind of see what we got and what comes out.
All right. Well, I'm Larry Hernandez. I am a licensed physical therapy assistant here in the Richardson, Texas area, and I have an outpatient clinic here. And we also do mobile care to patients' homes. And so our primary things that we like to work with, which we help all ages and conditions, for the most part, as musculoskeletal conditions. But I love working with shoulders, and I love working with patients that struggle with balance. And so that's what I do here in the Dallas-Fort Worth area of Richardson, Texas. So that's who I am, and that's what I do.
Yeah, awesome, man. And I know we kind of fall in line with some of, maybe we used to fall in line with some of our treatment ideas and stuff like that. I know based off of some of the stuff that you've done and, and the way that you work with patients is kind of what I call not necessarily abnormal, but I don't typically see it in traditional care and PT, which is awesome. It's more of just, trying to find the newest route to help patients, which is awesome. So, to kind of piggyback right off that and kind of go into our topic is just, how do you optimize, patient care, and whether that be post-surgical, which I know we've kind of briefly mentioned about, like protocols. And, you see a lot of those run-the-mill PT clinics that will just kind of, they get their 10 exercises, we'll say hip pain. And then it's just like for the first 10 visits, you're just doing the same exercises, which there's time and a place for stuff like that. But I think it's all too common right now. But why don't you kind of tell me a little bit, or tell everyone a little bit more about what you were just talking. I know you took a fantastic course this past weekend, and they were telling you some cool info.
Yeah, I'm probably going to misquote it, but I'm going to try and correct myself as I was talking to you earlier. But you were talking about protocols, and I think there's a time and a place for that. But what they were talking about was that there was a study, and actually, while we were talking here, if I looked like I wasn't paying attention, it's because I was Googling a study. But that protocols are great. Maybe we have a certain surgeon that has a TKR, total knee replacement. If you don't know acronyms and you're watching this, where some of the go-tos for total knee replacements do work, right? And so that could be a place and a time for that. But when it comes to shoulders, I think what has gotten me better results is that the one thing I do is I individualize the care. And that's what we're going to talk about today. I think one of the topics we're going to talk about is protocol care versus individualized care. What's better and in what situation where there's a time and place for each, right? And I think there's a time and place for individualized care when it comes to when protocols just aren't working, right? And that's what we do here at our clinic. We try to individualize the care with all our patients, whether they're insurance or whether they're paying out of their pocket. We don't get a lot of referrals from doctors. People find us, which is kind of a nice thing, and they want to work with us. And so, one of the things I think about when I think about the realm of shoulders and what I work with, a lot of the go-tos for shoulders is, hey, let's do this extra rotation right here. let's strengthen external, let's strengthen internal, let's do some isometrics. Those are the go-tos for shoulders. And I often hear from patients that like, yeah, I did this before, or I went to a physical therapist before and it didn't work. And when I have these conversations with people on the phone, if you're a therapist and a clinician here and you struggle with getting people in the door, this is one of my favorite objections is like, well, maybe that person wasn't the right fit for you because they didn't individualize the care for you. And so, you don't buy the first house you look at. You don't buy the first car you look at. You look for a right fit. And just like doctors, there's different specialists and they get different experiences. Physical therapists, we come from different schools and different schools of thought as well. And so maybe you just got a school of thought or maybe somebody taught that person at a school where they had a certain thing that didn't work for you. That doesn't necessarily mean that a physical therapist is not going to be able to help you. And so I rambled a little bit, but maybe you can respond to that. So.
Yeah, no, I mean, I think that's a very unique point that me and you've kind of talked. Obviously, we know a little bit more about it, but it makes sense, right? Like you said, if you have a family of 4, why would you try to buy a house that only has like 2 bedrooms, right? It's clearly not the fit. Not saying that the house has anything wrong with it, but it's just not the right fit for you. And whether, like you said, it's just a weird school of thought or like a different school of thought, I should say, or maybe it's an old school way of thought. Like you said, the go-to is just lay on your side and you start doing external rotation. And yes, there's a time and place for protocols, and I don't have anything necessarily against protocols, but I think it comes down to individualized care, like you said, and there can definitely be an overlap because maybe that person needs that protocol at that certain time. Like you said, like a total knee replacement or a rotator cuff, for sure there's a time and a place to follow a protocol, but not everyone is the same timeline. Different bodies heal different ways, whether they have different diseases involved or maybe they're perfectly healthy, they're young versus old. There's so many different factors. And it's definitely not a one shoe fits all category, and I feel like some lazy therapists, can fall into that category. Like, oh, I know this has worked before. I'm just going to paint it across the board, and then you get testimonies like you were saying, where it's like, oh, well, I've went to this one guy and it hasn't worked. So, to justify your rambling, I think it is a very strong point. And, it comes down to not really bashing on one person or the other. It's just like you said, it might not be a good fit, and that's okay. But you need to be aware as not just a client or a patient, but as a consumer, because you're spending money one way or another. And so you need to be aware, of your options. Like I have a strong disdain, and this may put me on a blacklist somewhere, but of, surgeons that have PT in-house, and then it's like they pigeonhole their clients or their patients into going to their PT. And it's like, that might not work for that patient. At least give them the option, like, hey, we have these guys in house, they're great, but be aware there's other options, and I know that may be a money scheme there too, but at the end of the day, I hate when people are just like, oh, well, I thought I had to because that's what he said. It's like, it's your money in your time. You can do whatever you want with it,
Well, doctors unfortunately carry a lot of authority when it comes to talking to patients. We talk about that a whole another topic, but they trust their doctors, right? But getting back to like individualized care, I was just writing some notes that I was thinking about as you were talking, and one of the things in that study they talked about that where PTs were excelling at helping people, because this was a study that he talked about where PTs were treating people and the ones that stood out. Right. And so the majority of people got better. There's ones that get better, but the ones that had the best outcomes were the ones that were offering, 2 things: individualized care, which comes down to a correct diagnosis of their dysfunction, and then two, individualized treatments, kind of avoiding that protocol thing. And so, and the way it looked like was the correct diagnosis came down to the correct dysfunction. Because you and me both know, kind of working around me, is that a rotator cuff can respond in so many different ways. And I had a guy come to me one time, and he had gotten PT somewhere else, and he had frozen shoulder. And he said that the PT gave him a protocol and it worked for him. And I said, but now he was coming to me for his other shoulder that was rotator cuff. And he went to that guy, and it wasn't helping him anymore. But he came to me expecting a protocol. And he was kind of upset that I was like, hey, like, I don't do protocols. It's going to be session by session.
Yeah.
I gave him an idea of what to start with based on what I saw in his shoulder. But I was like, but you're going to need to come in more. This isn't going to fix your shoulder, And so, he had certain dysfunctions that were going to need treatment that was going to be needed to be changed, right? And so, and he wasn't the standard rotator cuff protocol. He was going to need some treatment for developing abduction strength, right? Because it wasn't the rotator muscles that were affected. It was more his deltoid and his supraspinatus and his traps versus and that's why a proper diagnosis of dysfunction matters, not just a diagnosis of, oh, you got a tear in your rotator cuff.
Yeah, exactly.
Yeah, where it's torn matters, and also the dysfunction that contributed to that tear, because you can have the same tears in a shoulder, but the dysfunction shows up totally different, right? And so that's where I kind of shine. And then the second thing was just, well, let's talk about that. I'll go to the next topic after. What do you think of that? What do you think of that?
Yeah, I mean, I think you nailed the nail on the head there, and and I think it piggybacks off the idea of just not everyone is the same, right? Everyone heals different and everyone presents different. And I treat some shoulders here and there as well, just because I treat with athletes and stuff or work with athletes. But it's, 9 times out of 10, they'll go to their doctor like, oh, I had an MRI and there's some tear of the rotator cuff. And it's like, okay, I understand that completely. But let's see how you're moving, let's see how you're lifting. And because they'll be like, oh yeah, but they said I had this tear, which I have pain, but then they're doing all this crazy motion. I'm like, well, that looks good. What's really the issue? And I think you touched on a point too with there was a guy that was benching, a heavy lifter guy, and then you try to slow it down, right? So the dysfunction isn't necessarily a rotator cuff tear. It's like a stability aspect. Okay, you just don't have a stable shoulder, so you're putting more strain on the rotator cuff. And so, I think to your point, it's just like you said, it's like people have these expectations that I just need X amount of exercise and I'll be great, or I just need these 4, 5, 10 exercises, do them over a period of time, it'll be great. And it's like, if your body worked that way, fantastic, but I have a guy right now who's working with a PT, and he's coming to see me on more of a performance aspect. And it's like, if you don't fix the dysfunction, right, and you're just kind of fixing the cause, then, it's or I guess if you're trying to treat the injury versus the cause, and sometimes it can lead you down a rabbit hole and not get results. And then it's like, I've had that same question. Oh, well, can't I just come in once a month? It's like, well, you can, but the responsiveness, you're losing that. And the reason why we have you come in to, twice a week, once a week, is to see how you're responding and make those reactive changes so we can keep you progressing linear, in a line linearly.
Yeah.
I have to work on that
here and there with some setbacks in there, right?
Yeah. Well, that's a natural rehab process, but overall, right, there should be an upward trend. If you have some downs and ups, that's normal. 100%. I agree with you. But I try to tell everyone that, but it's like, would you rather go little bumps, or would you rather do this because you're waiting too long, or you don't know? But again, to not rant a ton, I think, like you said, everyone's different, and that's kind of where we thrive, is that individualized care and reacting to how your body is reacting. especially as clinicians. So
yeah, and MRIs aren't accurate all the time as well in regards to what's actually causing the pain, right? Because there are studies out there. Maybe I can put it in the comment section of this podcast, but there are studies out there where people have things wrong in their MRIs, but don't have pain. And so, what I'll tell a lot of patients of mine, sometimes they do reach out to me first because they find, you know, a podcast or my Instagram, or they hear about me through someone or a Facebook, and sometimes the first conversation is like, well, I think I'm going to go to MRI first. I'm like, okay, well, why are you going to go to MRI? He's like, well, I know something's wrong with it, so I just want to know what's wrong.
all right.
Like, well, what if there's something wrong in there and you didn't have pain? Would you still go get an MRI? And he was like, no. I was like, well, there's people out there with MRIs that have things wrong but no pain. So what I'm getting at is that your MRI might show you what might be torn there, but that might not necessarily be why you have pain. And so I've had people have tears in an area where the dysfunction was nothing related to that tear, right? It was, you know, tear in the teres minor, but their dysfunction was an abduction issue, right? And so that's what I try to tell them, and they're like, "Oh, I didn't know that." I'm like, "Yeah, there's studies." I was like, "Here, I think I have a blog post on my website I can share." But yeah, it's like, hey man, just save some money.
Yeah,
you're gonna spend $500 to $1,000 and go get MRI, and then now you're like, oh, I don't want to spend, you know, whatever we charge, you know, which is ranges all over the place as far as physical therapist.
Yeah.
The average around here in the Dallas area is $175 if you want individualized care. But anyways, yeah, MRIs aren't going to show you your pain, you know?
Yeah.
So, yeah.
Oh, no. And I see that all the time, whether I be treating knees or ankles, especially. People are told all the time like that they're, what is it? CFL, yeah, it's just like gone and obliterated. And they're like, what am I supposed to do? I'm like, you probably did that forever ago when you were a kid playing some reckless sport. Like everyone tears, you know, that particular ligament in their ankle. It doesn't mean like, are you more prone to instability? 100%, but that's probably not why you have an actual injury, you know, or where the pain's coming from. Like you probably sheared that off forever ago. Or knees, you know, it's kind of the same thing. And I know people, and I think I don't know where it stems from, to be honest, but the stemming from like, I need to know exactly what the issue is, because it has to be, they're like, it's my body. There has to be one tissue. There has to be a rotator cuff, or it has to be a labrum. And it's like you said, it's like, man, the amount of times I've had that same conversation of being like, okay, great. You know, especially with leg pain. Oh yeah, I have leg pain. And so I got an MRI of my back and they said I had a bulging disc. I'm like, okay, well, did you have leg pain, you know, like a month ago? No, it just kind of happened. Well, it's probably not from your low back then. It's probably something else. Or maybe it is, but either way, I doubt those bulging discs. And I tell everyone, if I had an MRI of my low back, it would probably all 5 lumbar discs, if not 6, would just be like, I'm sure they're all discombobulated, but I still function day to day. So it's like, where's your function at, and I guess how can we get you back to the function that you want? Like the imaging very rarely tells us, like you said, the actual
picture.
Yeah, the whole picture. It could be a piece for sure, not to take away from it, but it's not like it's the end all be all. Oh yeah, okay, now we have, you know, the answer right here now that we know. So
yeah, I mean, if it's something obvious, like, hey, you have a fractured vertebrae,
right?
Hey,
yeah, okay. That's it.
Right? yeah. You know, and I think they were talking about the class this weekend where neck fractures sometimes get missed on MRI, and this doctor referred someone to the PT, that the guy that was teaching the class, and he wasn't getting better. And then they were asking him to do manipulations, and he was like, I don't know, there's something weird about this. And they're like, well, his x-rays are clear and everything. And the one thing they didn't do when they did his x-rays was have him open his mouth. He had a fracture at C1, C2. Ooh. So your teeth can block what can be seen back here in the C1, C2. So if he would have manipulated this guy, that could have been
a good time.
very ugly. So what they do, they stabilized the guy. He healed in 6 weeks, 8 weeks, whatever it was. He was in a CrossFit competition this week, actually, like the therapist was saying. So again, the only way they found that out was because the therapist evaluated him and it was like, I'm not gonna do that. There's something going on, and I can tell based on my evaluation, and so the PT referred out,
Yeah.
so, yeah, that's crazy.
That's kind of nuts because like you said, that can and it's cool to hear though the not necessarily the independence, but just like the clinical reasoning, right? It's like you have the doctor saying, or the MD saying, "Oh yeah, well we checked the X-rays. It's fine. Just manipulate them. It'll be, it'll work out." And you're like, I don't know, because I've seen some good stuff and I've seen not some good stuff, and that's kind of a sketchy point. And to have the I don't know, the independence to be like, no, like I'm gonna kind of put my foot down. I think there needs to be a further follow up. I think more therapists need that to like go out of their comfort zone and be like, no, like it's my license on the line at this point. Let me, either say yes or no with my clinical reasoning versus just being like told. So
yeah. They were told, hey, here's the protocol. You're great at neck manipulations. It's worked for all your other patients. Do this, right? What if they were there at a place and they're like, hey, this is what you're going to do with every neck patient regardless, right? So get comfortable with doing it. We're going to write the orders. You do it, right? But no, like, we're supposed to use our clinical reasoning and be like, hey, there's something wrong here, So, yeah. One thing I was talking about dysfunction, I think we touched on it a little bit earlier. I wanted to backtrack a little bit. It's like, what is dysfunction, right? And when we talk about the shoulder, even the body in general, I like to say 4 categories. I say it's stability, range of motion, strength, and coordination. And so what that looks like with a shoulder is, somebody might, lack range of motion, but then passively I can pull them up, right? And so they're either lacking strength or stability. Or coordination of the scapular glenohumeral complex, right? And so that is how we get a proper diagnosis for a shoulder, right? You work with runners. What are some things that you see when it comes down to proper diagnosis of dysfunctions?
Oh man, I think a big one for runners tends to be either at the ankle and at the hip. And so with the ankle, it tends to be more of a stability issue. And as well as, and I say proprioceptive, but it doesn't necessarily mean balance. It means like they don't necessarily know how to move their ankle or control their ankle. So it becomes that kind of coordination issue there of like, okay, this is how you actually
do whatever, right?
Exactly.
Because they've had an injury. It's kind of like when I work with balance patients and you close your eyes and they start losing their balance. So it's like you're essentially, when you're running, you don't look at your feet. I mean, maybe somebody does, but if you're not looking at your feet, you don't know what your foot's doing. And what if it needs to be corrected, right? And we need you to strike on your foot, on the ball of your foot, or wherever you suggest. I think that's what you suggest, right?
Versus midfoot, the ball,
versus your heel, right? And they're like, well, I think I'm running on my ball of my foot. And they're like, oh, really? Well, why don't you just take off your shoe and take a look at your shoe and tell me where it's worn out right now?
Yeah. But then, to kind of speak on the coordination issue, that one tends to come from the hip. So like when people have, they're having hip pain or knee pain, sometimes it's on the opposite spectrum. It comes at the hip and they don't know how to engage their hips in a single leg stance, let alone, while they're moving. And so those are kind of the 2 dysfunctions that I really see and work with runners. And I mean, and at the end of the day, I kind of teach both because, I show someone you could still have relatively strong hips, but not know how to utilize them in a single leg stance. And so when you lock in your ankle with your muscles, then you start all of a sudden having to use your hip for balance. And so if your hip coordination doesn't know how to align when your ankle is coordinated and stable, then you start going up the chain and causing other problems. So it's like you start have to, correcting these dysfunctions, and they're like, oh wow, I just thought I had knee pain, or I thought I just had a shin splint. I was like, well, yeah, that's because of all this other
All the
things
people
aren't,
around it.
yeah, are just kind of doing errant things. So, I think that was a great, well-defined, well, I guess, definition of dysfunction. Like you said,
it's a short list too, right? Because maybe that's
yeah,
what we've been taught, right? I mean, might be somebody down the road that might know more than us, right? Because I've told people like, hey, I think I had a knee patient recently, and I think your schedule is full. And I told the patient, I was like, yeah, I don't mind working with runners. I was like, they're not my forte. I was like, actually, you would probably do better with Cole. I was like, his schedule's full right now, but if we get an opening, we'll try and get you on there.
yeah.
And like, oh, so you don't like runners? I was like, no, I don't like runners, but I'm willing to be humble enough to be like, yeah, maybe I'm out for you. And then I've helped many knees, but I love shoulders, so I like working with shoulders. So I wanted to change topics because we've probably hammered that one a little bit. So what does a individualized care session look like? I'll leave that up to you, and then maybe I can piggyback on that one.
Yeah, and to me, I think or at least I know I touched on it. It's just kind of like assessing what you need as a person, and then doing just that. So and that's probably as simplistic as it can get. Is if you come in though. Yeah. But, it's like if you come in and whether, even if you're not a runner and you're just saying, I'm an old lady with hip pain, I don't need to run, but I need to be able to go up and down stairs. That's going to look significantly different than someone that maybe has the same hip pain, but now they're 38 years old and they're like, well, I'm trying to run a marathon. It's like, okay, we need to address this completely different because your goals are completely different. Right. And so that's where I feel like the individualized care kind of shines, because it's like, yes, you could even have the same exercises, but the end point of where that evolution of that plan of care is going to be vastly different. How quick you progress, how, which exercises you progress, and then, working on that. So I think to me, that's kind of what a individualized plan kind of means to me, is like, you're not just doing that cookie cutter thing. You're doing everything with a reason towards that person's functional or athletic goal.
Yeah, I like that. Yeah, one thing he said about the study that made sessions better was that, just to piggyback on what you're saying, is that like each session might be different, right? Because when we're talking about protocol care, doctors will write 6 weeks range of motion or strengthening, or 6 weeks of these 3 exercises.
Yeah.
And so individualized care is going to be like, what it looks like is the sessions are going to look different every time, right? And so when that patient comes in, we don't immediately, all right, go get on the new step, or go get on the upper extremity erg, or well, maybe we do that, but then we're talking to them and saying, hey, how did the week go? We gave you some correctives last time to correct these dysfunctions. How did they go? How many times did you work on them? And what was your response to those movements? What was your response to last treatment, right? What things were working, right? How did those things feel? Because so we cause irritations. PTs, we cause irritations.
Yeah.
I like this saying that one of my mentors says, I think it's him, Dr. Sean Pastuch from Active Life RX, is that he says irritation drives adaptation. And so if you want to make changes, you got to irritate yourself in some way. You got to make your muscles work. You got to, put some weight bearing through bones in order to make change. And so we're trying to figure out, like, well, what we did last time, what type of response happened, right? Too much. Was it sharp? Was it dull? Was it achy? Did it cause, if you work with a back patient, did it cause paresthesias down the leg? Was it more? Was it less? We're trying to figure out, like, what did we do last time and how did it affect you? And then our clinical reason is going to make us, choose a direction of where to go that day. And so we're going to work with your hips today because, you said it referred that way. So we're going to take a look at that. and work those hips today. Or if it's a shoulder, I might say, oh, we're going to work on some neck range of motion today because you're saying your neck's hurting, right? And so they're closely related. So we're not just going to treat the shoulder. If protocol tells us, hey, do these 3 or 4 exercises regardless if their neck hurts or they're getting headaches or their scapula is hurting. We're not just sit there and just disregard the patient. We're not, and that's what sometimes happens, right? There's been patients that come to me and they're like, yeah, they just disregarded my comments or my complaints and just, oh, that's how it is. Let's do this.
Yeah.
What do you have to say about that?
Oh man, I have so many things to say, but to kind of steer away from the from the negatives is that it's just that is I feel like a lot of those big chain kind of corporations sometimes you see so many patients and you just kind of fall into that kind of, oh well, it's fine, it's natural, it'll work itself out. But and to your point, it's kind of like, well, for true individualized care, it's like I need to care for you as a person. So if you're telling me that maybe you didn't have neck pain last time, but now you're having neck pain after these exercises for your shoulder, okay, well, let's look at what you did, whether it be with the exercises, what you did at your home. Maybe you're progressing, but now that true symptoms are actually, showing up with the neck. So let's, like you said, like, let's take a look at what's going on there, and figure it out, and get you feeling better. So it's to that point where it's like you said, I think responding to the patient in a very, and obviously reactive is one thing, but it's just proactively, I guess, is a better way that I would like to put it, because, a human body is always kind of be reactive. And, to your point, it goes into therapists cause irritation so you can get adaptations, just like you said, and that's the way the body works. That's the reason to why it's so versatile and in any environment. So yeah, to not go too negative, I think more therapists could do a lot better with just listening to their patients and actually addressing them. Their complaints, their feedback, etc. I mean, I go through all of my sessions, even during the session, and just say, hey, how do you feel? Like, what are you feeling now? Do you feel great? Do you feel like soreness? Do you feel like you have sharp pain? Because I know a lot of patients, if I don't say anything to them, they'll just keep going. And they're like, oh no, I did have sharp pain about like 3 exercises ago, and now it's just kind of bothering me. I'm like, why didn't you tell me that during this?
Was it challenging enough, or was it too hard? Going back to other types of patient responses, like times where I'm like working somebody and they look like they're just sweating it out, and I'm like, is this too hard? Like, tell me. Or like they're flying through things, and I'm like,
oh yeah,
do you need some more weight? Like, your shoulder looks like it's doing better, but yet we're doing 8 pounds today. And I was like, I know I told you the goal was to get to this poundage. And like, if your pain's not bothering you and you're flying through this, let's go. Let's load it up,
Right. Yeah, I know. That's patience and underloading is usually the problem, I would say. So they don't understand when to be pushed, and that's always a fun conversation to have too. It's like, no, we're going up in weight. Come on.
I got this quote here from a study I found. It's not about PT, but it was about hospital care. It says, if recommendations lack flexibility, they risk benefiting some patients while harming others. Allowing individualized care, in contrast, empowers providers to utilize all available evidence while still exercising their clinical expertise to provide the very best care for individual patients. So, bam, I like that.
Yeah, that's a good one. I think that's what it comes down to. The big word there that I took out is just flexibility. I mean, in healthcare and patient care, I think that's king. And I think that's kind of the individualized care at the bottom of the day. It's just, are you flexible enough to respond to your patient?
Yeah. Are we humble enough to be like, hey, we need to change something, right?
Yeah, exactly. And having that humility, like you said, because even though it's worked for 100 of patients, you have that one patient that comes in and says, look, it's causing me more pain. It's like, okay, don't tell them to push through. Just take it with it, what it is, and, you know, respond. So cool. Any other tips there we got as we start rounding out our time on
as for example here, I wrote all over your desk because I was using the desk here. So
oh, fantastic. It's a great desk to write notes. Nice. Glass desks are, you know, it's the wave of the future, I think. Though I did have someone say that someone needs to create a desk where you can write on it and it automatically imports it into the computer. I said,
that would be cool.
Yeah, I was like, if that is ever a thing, you can count me for my investment because that would save me so much time. But awesome, Larry. Well, great talks today. I think hopefully, like, you know, people understand the kind of difference between individualized care and just kind of either protocols or just kind of a rote memorization care, and, you know, the benefits that can really come from seeking out individualized care. And, you know, not one size meets all, but all meets many, I guess. I don't know. I'll come up with a better quote. But yeah. Any ending remarks on your end?
One thing I think maybe I forgot to talk about, but I'll just leave it as a comment versus we don't have to dive into it. But I think one thing too with individualized care is technology. I've invested in some tools here at the office that have gotten us better care. And one is the shockwave, and the other one's the laser. And those have been game changers and kind of getting me some outcomes with my patients. And so when you work with someone that can give you individualized care, they're going to invest in things that can offer you better care, because those are not typical machines in PT clinics. And because they're not reimbursed. There's plenty of studies that say, hey, they work, but, insurance hasn't caught up and say, hey, we'll pay for it,
well, that's a whole nother conversation too. But I mean, like you said, the provider's not only going to invest in themselves, but they're going to invest in means that benefit their patients. So I think it's another great little tip for those kind of listeners or just future clinicians. Don't just invest in yourself. Invest in things that you think will benefit your patients. I like it. That's a good one.
Awesome. That's it, man. That's
all right. Yeah. We'll pick it back up in a couple weeks. We'll get another podcast going. If anyone out there has any other ideas or wants us to talk about anything specific, you can always leave it down in the comments or shoot us a direct message and we'll put it on the old brainstorm board and make sure we answer those. But otherwise, Mr. Larry, I'll catch you next time on this beautiful Muscle and Minutes podcast, and hope you have a great rest of your week, my good sir.
All right, man. Take care.